What is neuroblastoma? And I think you'll find out from the next few minutes, it's so many things. And if your experience with your child with neuroblastoma is really different from the experience of the person or the family sitting next to you, it's because the disease is so many things, and your experience is going to be uniquely your own. The next few slides will go through a number of different aspects of neuroblastoma, sort of a tasting menu for what many of my colleagues will talk about over the next 2 days. So key messages: neuroblastoma is a tumor of the developing peripheral nervous system. See, I spelled it with a U, tumor. I did it right. And I'll talk a little bit about what that means. The biology of neuroblastoma is quite complex, and we're trying to learn more and more about it by the month, by the year. Treatment depends on risk classification or the risk of disease recurrence. And we have to stay humble all the time as we think about neuroblastoma, as we study neuroblastoma, and as we care for you and your children, because we have so much more to learn about this disease. So first, I know all of you know this, but your friends and your family and your third cousin twice removed next door neighbor might hear the word neuroblastoma and think that it's a brain tumor and say, "I'm so sorry, I heard your child has a brain tumor." No, 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 you have to say. Neuroblastoma is not a brain tumor, even though its first name is neuro, which would make a lot of people think that it's a brain tumor. In fact, neuroblastoma is a tumor of what's called the peripheral nervous system, so the nervous system outside of the brain. And as you can see in this diagram, the peripheral nervous system runs basically next to the spine, and you can see its nerves, nerve roots, and the adrenal glands comprise the peripheral nervous system. And so what you get are tumors primarily in the abdomen, most commonly in the adrenal glands. As you can see in the slide, the arrow on the lower, I guess that's your right, is an adrenal primary. And up above, the two big red arrows on either side of the spine show disease along what's called the sympathetic chain. And those are common sites for neuroblastoma in the body as part of the peripheral nervous system. Why does that happen? Why does neuroblastoma end up in the peripheral nervous system along the sympathetic chain next to the spine and in the adrenal glands? Well, it turns out that neuroblastoma cells come from what's called the neural crest in the developing embryo fairly early on in the development of what's going to be a baby. And the neuroblastoma cells migrate, the neural crest cells start, is this a pointer? Well, maybe it's not, but think about the head of this little tiny, oh, I can walk. This cells start here and migrate basically along the back. And in an orderly progression, in many of us, the cells migrate down along our spine and land at the adrenal glands, which is pretty amazing when you think about it, that those cells migrate, they know where to go, they know when to stop, they know when to divide and not to divide, and most of the time it works out just fine. But in the case of children with neuroblastoma, that migration and that starting and stopping and moving and staying still gets messed up in whatever way that we don't completely understand, and you end up with neuroblastoma tumors. Sometimes those tumors will migrate and forget to stop dividing and end up next to the adrenal gland as a localized tumor. As you can see, there are two kidneys sitting on either side of the spine, and below the one on the left is a tumor. That's the neuroblastoma. But sometimes more happens than that. In the next two pictures, you can see that above the left kidney, there's something sitting on it. That's a neuroblastoma tumor. But cells also migrated in the liver and forgot to stop dividing and grew and multiplied. And now there's a liver full of neuroblastoma cells. And in the slide on your left, there you can see almost the whole abdomen is full of tumor, and that's a very small baby with a very big liver full of neuroblastoma cells. Why did the first child in the top part develop just neuroblastoma in one spot, and why did the child in the second set of slides develop disease that's both in the liver and next to the kidney? We're beginning to think we understand that, but we don't completely have it down. But those are two of the faces of neuroblastoma. Many of you in the audience will have experienced a situation more like this last set of slides, a child who not only has a tumor in the abdomen, but the cells also have migrated to other parts of the body, including multiple bones, lymph nodes, and the colorful panel is disease in the bone marrow. So these are many different, what we call clinical presentations of neuroblastoma, but it all comes from the neural crest and these errors or mistakes in migration and cell division. So when does this happen? Where does this happen? Why does this happen? To me, this idea of developmental biology going slightly wrong is intriguing, and it's something we really need to understand why neuroblastoma happens. And we're trying very hard as a community to understand what happens at the cellular level, what are the signals that get confused, to try to understand the start of your child's neuroblastoma. But we do think that this complicated developmental process is at the root of it and explains why neuroblastoma can behave in so many ways. And what's really interesting for us as clinicians is that neuroblastoma sits at the crossroads of so many parts of science: developmental biology, pharmacology, radiology, immunology, cell signaling. Any part of science that you can think of touches on neuroblastoma. So we have to really come together to think about why neuroblastoma happens and what to do about it. So when we see children with neuroblastoma, we see the little baby sleeping peacefully in this picture. And this little child had a relatively small adrenal mass, never required any treatment, and her mom allowed me to use this picture, but perfectly fine, no surgery, no radiation, no chemotherapy, just observation, and this child is beautiful and doing great. Another patient whose mother also kindly let me use this photo presented in a very different way. Some of you may have seen your own child or another child with involvement of the bones around the orbit and that black and blue appearance, sometimes referred to as raccoon eyes. This little child had a much more complicated abdominal tumor and involvement of bone and bone marrow, and she was treated with multi-modality therapy, including chemotherapy, surgery, MIBG therapy, high-dose chemo with stem cell rescue, radiation, immunotherapy, Accutane as differentiation therapy, and unfortunately her outcome was not as good as some of the other children with neuroblastoma. So how can this be the same disease? How can you have one child who requires essentially no intervention and does fine, and another child who receives every treatment that we can possibly think of and unfortunately did not survive her disease? And when we talk about it in the same breath. We call them both neuroblastoma. That seems unbelievable, but it's true. When you look under the microscope, those cells look the same, but we all know that they're really not. So there's a long history of research that helps us understand this conundrum, this confusing fact that neuroblastoma can behave so differently. So we have long been able to look under the microscope at the cells and say those cells look more aggressive, more packed in, less grown up, less differentiated compared to some of the other cells. So that's pretty simple looking under the microscope, but still important. In the 1980s, Gerrit Brodeur, Manfred Schwab, and others uncovered the fact that there is a gene that drives a very aggressive kind of presentation of neuroblastoma. And when you have too many copies of that gene called MYC-N, the cancer often can behave in a very aggressive way that you might not have been able to explain simply by location, presence or absence of metastatic disease, or the appearance under the microscope. So this was the beginning of the idea that something is driving neuroblastoma that our eyes can't immediately see. So MYC-N opened the door into thinking about tumor biology. Around the same time, we started to understand the importance of looking at the DNA content in total. And we learned that patients who have different amount of DNA in their cells might have different outcomes with the same therapy administered. So this was old news back in the 1980s and early 90s, and the exploration and discovery has continued to this day. So what this looks like today is beginning to look at changes in the DNA sequence of tumor cells over time, whether through biopsy of tumors that respond to therapy and then come back, or looking at liquid biopsy that you'll hear a lot more about from my colleagues later today. But this has really come a very long way in looking at a single gene versus sequence changes in many genes in neuroblastoma cells. In addition, we're looking beyond just gene sequence and looking at all the other complex things that happen in the body as DNA encodes RNA, encodes proteins. Those proteins are modified. There's so many other levels of inquiry that some of my colleagues sitting at the table are very interested in and teaching us every day about the biology of neuroblastoma. If this seems complex and overwhelming, it's because it is, and I won't spend more time on this today, but invite you to the ANR, Advances in Neuroblastoma Research meeting that happens every 2 years. And this is where we sit and learn from our basic science colleagues about really what's happening on the molecular level in neuroblastoma and how does it apply to patient care. But let's get back to basics. I got a little far afield there. When a patient comes in the year 2025, the first thing we do is a biopsy to understand, is this really neuroblastoma? It walks like a duck and quacks like a duck, but is it a duck? We better prove that. And so in most children's cases, we'll get a diagnosis, nowadays usually with an interventional radiology procedure, but sometimes still with a surgical biopsy. And we look under the microscope and say, behold, this looks like neuroblastoma. Getting enough tissue is really important for all the complicated studies that we need to do to understand the biology of the tumor and how it might behave. So we want to do these key profiling studies for therapy selection. This is the usual dogma, do a biopsy, learn more, but there are certain cases where we don't want to do a biopsy or we shouldn't do a biopsy. And the first one is that little baby I told you about who had a small adrenal mass noted right after birth. No biopsy indicated, and that patient is fine. And that's a very specific group of young infants. There are other infants who come in, like the patient I also showed you before, with a belly full of tumor, mostly liver, but you can see that that patient probably is not feeling well, not doing very well. And there's some patients where we don't biopsy and we just have to use our clinical judgment and say, let's start this patient on treatment. We'll get a biopsy later when it's safe. So that's another presentation that you might have heard of or experienced. In the future, I would hope that we can use some more sophisticated and less invasive techniques to be able to learn more about the tumors of those children I just told you about, but also about the other children who might not actually 5-10 years from now need a tumor biopsy, but instead perhaps be able to undergo a liquid biopsy, identify that this is neuroblastoma, identify some of the genes that are most important in determining how to treat the patient in a less invasive, easier on the child type of way. So that's just a little glimpse into the future, I hope. The second thing that happens after the establishment of the diagnosis is to do what's called staging. So figure out where is the tumor in the body. And typically that means looking at the main site of the tumor or the primary tumor, generally with a CT or an MRI scan. In addition, we look at sites where the tumor has spread, metastatic disease, with an MIBG scan, or in the rare patients whose tumors don't light up on MIBG scan, we can do what's called a PET scan. And finally, we look at bone marrow, which is difficult to tell on an MIBG scan or difficult to tell on a CT or MRI. And we actually do a minor procedure where we take a little sample of the liquid part of the bone and a little piece of bone marrow surrounded by bone and look at it under the microscope to determine if tumor has spread there. Based on all of those tests, we assign a stage. Localized tumors can be either pretty simple and just a circle, looks like a golf ball or a grapefruit sitting in a child's abdomen, as you can see in the slide labeled L1. And a surgeon would look at that and say, let me at it. I want to take this out. This would be a great thing to do. I can make this kid better. And then the second panel down below, L2, is where a surgeon says, do I have to? You really want me to go after that? That's a more complicated tumor that's wrapped around structures in the body and needs a different approach rather than a quick operation. Those are localized tumors, L1 and L2. Then we come to M, which stands for metastatic. So those are patients who have tumor that has spread to bone, distant lymph nodes, or bone marrow. And then finally, there's a special case called MS. The S is for special. And those are very young children, typically under 18 months of age, and have a particular pattern of sites that Meredith, I think, will mention to you, based on very keen clinical observations made by Audrey Evans many years ago. So these are basically the 4 stages. We don't so much talk about 1, 2, 3, and 4 anymore, but typically L1, L2, M, and MS. And then we put the information that we have together to talk about what is the risk of relapse for this patient. So many of you have heard of a child who has intermediate risk disease or high risk disease. And so that process of assigning that category is called risk stratification. Most of the children who need a lot of therapy and most of the children who go on to relapse have high risk disease. But it's important for us to remember, especially those of us who spend so much time thinking about high risk and relapse neuroblastoma, that about half of the patients that present with neuroblastoma have non-high risk disease, have low risk or intermediate risk disease. And it turns out that those patients generally do very, very well. So we just don't want to get so focused on relapsed or high risk disease that we forget. Determining a child's risk group is absolutely critical, sort of from the Goldilocks point of view. You don't want something that's too big or too small. You don't want to undertreat someone who needs high-risk treatment. You don't want to overtreat a child who actually has intermediate risk disease. You don't want to give them high-risk therapy because that comes with a lot of short, intermediate, and long-term side effects. So getting it right from the beginning is really, really important. Some of the factors that come into play are the age of the patient, and the under-over is 18 months. The patient's stage, as I just mentioned, how it looks under the microscope, called histology, the presence or absence of multiple copies of the MYC gene. Remember, that's from way back in the 1980s, and still stands today as a very important prognostic factor and factor that helps us with risk classification even now in the 2020s. And then currently we use the presence or absence of additional pieces of chromosomal material known as segmental chromosome aberrations. And some of my colleagues will talk about that a little more in detail with regard to risk classification. But these are the things that we use today in 2025 to determine whether someone has high risk, intermediate, or low risk disease. And here's my favorite figure by none other than Meredith Irwin sitting in the front row. But I look at these tables from this paper. I've been doing pediatric oncology for 25 years. I take care of a lot of children with neuroblastoma at the Children's Hospital of Philadelphia. But I still look at this paper probably at least once a week, I would say. Because sometimes it can be really tricky. A lot of times it's very straightforward to assign a risk group. So a child over 18 months of age with metastatic disease has high-risk neuroblastoma. That's not very intellectually challenging. It's therapeutically challenging and emotionally challenging, but assigning risk is not that hard. Same thing with a little child with a easily surgically removable tumor and no metastatic disease. That's low risk. But sometimes it can be very tricky and you have to think about all these different factors that come into play in assigning the risk group. So no shame in using our colleagues' diagrams to help us make the right call about risk. Sometimes they're really significant challenges, and a lot of times we have to wait for additional results from, for example, from DNA sequencing studies or other studies to help us make a decision about which risk group should a patient be in. And this, from a parent's perspective, is simply terrible. They want to know what's going to happen next, and sometimes we have to all take a deep breath and kind of pace with it until we have all the right pieces of the puzzle to assign risk properly. Sometimes we have to give some therapy in an urgent or emergent basis while we're waiting for all the information to come in, again, to assign risk properly. And there are sometimes patients who have unusual clinical presentations, and I don't say the patient didn't fit the algorithm. No, the algorithm didn't fit the patient. The patient has what they have, but we as clinicians sometimes have to really puzzle about what to do. So the patient with the mass in the chest, whose arms are up like this and has a big mass pushing on their windpipe, presents a certain scenario where they might technically fall into a higher risk category, but with a brave surgeon and favorable biology, might not fall into the high risk group that one might think originally. And another patient in the panel on the left had a very complicated tumor, and some road signs might not point towards high-risk therapy, but some of the other characteristics might point us in a different direction. So there's some situations where risk classification is very straightforward, and other times where we really have to scratch our head. And you may hear of a physician talking to their colleagues, consulting with others in the neuroblastoma community, because it's so important to get it right. And again, there's no shame in that, just like there's no shame in checking the algorithm, because we really just want to do the right thing by each and every complicated patient. So that's me at my computer emailing some of the people you'll see for the rest of the day. It's important to understand that risk stratification has evolved over the decades that we've been applying a risk stratified approach, and it's going to continue to evolve. So this figure is from the paper, where's Lee? Of one of our colleagues who will be speaking later today about new imaging technologies. So this is using an MFBG tracer rather than an MIBG tracer. And it gives beautiful pictures, but may also pick up additional sites of disease that we didn't appreciate on the technology that we have been using. And this is really important because we may have a patient that we thought had localized disease. We pick up something new with our fancy tracer, and now we say they have metastatic disease, but the implications of that aren't totally understood yet. So we have to take new technology, be excited about it, but also be thoughtful about what does this mean for the patient in front of me, and what does this mean for how I think about risk for that child. The same is true, again, of liquid biopsy. It's very attractive because we would like to have fewer kids need to get scans all the time, need to get bone marrows, but we need to understand how to use it wisely before we start doing tests and then end up with information that we don't understand. So risk stratification will evolve, and I think these new technologies will be incorporated probably within the next 5 years or so, but we have to do it step by step and be smart. So I'll briefly go over our approach to treatment, and then many others will talk much more than I will. But to address non-high-risk disease, the biggest move in the last 10 to 20 years has been to reduce the potential for harm. So many patients in the battle days were treated much more aggressively with their low and intermediate risk disease, and we don't want to cause any more trouble for those patients in terms of late effects than they actually need. So some patients don't need any treatment at all. Some just need surgery. Some need a little bit of chemotherapy to get them over the hump, and they're going to be fine. And some need a combination of chemotherapy and surgery, and you want to be smart about how to use those tools to minimize the likelihood of late toxicity. We want those kids to grow up and be completely well. On the other hand, high-risk disease is a much different kettle of fish. This is a Kaplan-Meier curve, which you may see throughout the day, and what it shows on the x-axis are the years from diagnosis, so that's time, and on the y-axis is event-free survival, and that's generally speaking survival without relapse, with a few exceptions, but we'll go with that. And what you can see is over time, in the lowest curve, the solid line from the 1990s, from the time of diagnosis up through year 5, the curve drops off very steeply because in the first few years from diagnosis, children relapsed quite quickly, and the survival rates were truly terrible, just over 20% at 5 years. And I'm not going to tell you exactly when I started in this field, but the curves were pretty bad when I first started, and what I said when I first started treating patients was about 25% of patients will be alive and relapse-free at 5 years. That's a very different story to what we say now, and you can see incrementally the curves have gone up, up, up. And so the most recent data that we have was from 2015 to 2019. You can see that the curves still drop off, and at 5 years, the event-free survival is just over 50%, which is truly not where we want to be, but appreciate where we've come from. So the event-free survival going from 25 to 50% is a real improvement. Like, that's double what it used to be. And I think everyone in this room would like to see it double again before we walk out of here and say, job done. So we still have a really long way to go, but we've really made significant improvements. And that's through an approach that I'll explain to you right now. However, it comes at a significant cost. And many of you have sat through a conversation about high-risk disease, and sometimes a little bit you are just so focused on what do I need to do next for my child, and sometimes you're able to hear and think about some of the late effects of high-risk therapy, but there are many. And we're just beginning to appreciate in a real way what those side effects are. So hearing loss is a significant issue. More than half of kids in the children's oncology group experience with high-risk therapy develop hearing loss that's significant enough to need hearing aids. Some patients have renal dysfunction, growth issues, fertility issues, other kinds of issues like second malignancy, which is thankfully quite rare, but not zero. So we have to really think about how far we've come, but we also have to think about the toxicity that we expose children to and try to do better with both of those aspects. We have a long-standing paradigm on both sides of the ocean that includes intensive induction therapy designed to decrease the disease burden, primarily through chemotherapy and surgery. Consolidation therapy means that you're digging your heels in. You've made progress, and now you really want to firm that up. And that's typically done with high-dose chemotherapy with stem cell rescue to help recovery, and radiation as well. And then post-consolidation, harnessing the body's own immune system to fight any neuroblastomas cells that might be left behind. And that paradigm is the same in many parts of the world. However, this paradigm has recently evolved, and I think there'll be some discussion today about that evolution. There continues to be induction, consolidation, and post-consolidation of different flavors, but we are still trying to learn more about what agents and what timing might impact the outcome. Does early introduction of targeted therapies like ALK-directed therapy, MIBG, other agents, does that make a difference in our initial response to chemo and in our long-term outcomes? Is high-dose chemo with stem cell rescue still required? And I know that's a very hot topic, and we'll talk about it probably through the day. Radiation, we kind of sometimes gloss over radiation, sorry, Mark, but what sites should be radiated, what dose should be used, those are really important questions in our field. Which patients truly benefit from immunotherapy? It's now been adopted across the board in most institutions on both sides of the ocean, but we still don't know really which patients get maximal benefit from immunotherapy and which just experience toxicity. And now in the modern era of immunotherapy, could we subtract some of the other things that we administer to children? I think probably so, but we still don't know which ones and in whom. So lots to learn. And then finally, what about continuation therapy? So a child goes through all this treatment, and then suddenly they're done, but Can we improve survival by adding additional therapy onto the end? So continuation like vaccine therapy, DFMO, or perhaps other agents. So lots to talk about. We have so many questions, and we need the expertise of everyone. We need surgeons, we need radiation oncologists, we need our pediatric oncology colleagues from around the world. We need pharma, we need our drug companies to be on board with us for sure, and we need our regulators, the EMA, the FDA, all the other people who help with drug development and drug approvals to also be on board. We need our laboratory scientists to continue to help us understand the biology of neuroblastoma and test new approaches, new drugs. And finally, and really importantly, I stole this from the SKC website, we need you. We need the parents, we need the families, we need your inspiration, your thoughts, your opinions on what really matters and what doesn't. So it's really got to be a community effort to try to improve the outcomes and also decrease the toxicity that kids are exposed to. If, again, shameless plug for ANR, if you have found this little preview interesting, and if you are even more interested throughout the day, please join us. There is a parent component to the ANR meeting in May.